Thank you, sir. Moving towards our next session, which will be a much interesting one. The word diabesity. This word itself is the most threatening combination in this era. I guess the insulin resistance, diabetes, and obesity has made a beautiful love triangle, and they have threatened mankind in a wonderful way. So, how to prevent it? By pharmacotherapy or by surgical therapy? We are going to experience a rumble in the jungle on the stage. In the blue corner, we have Dr. Shottam Chakraborty, who is the champion of pharmacotherapy. And in the red corner, we have Dr. Sarfaraz Zareen Beg, one of the senior most GI surgeons in Kolkata. And as a match referee and moderator, we have Dr. Shomudra Gupta, senior consultant physician with wide experience in internal and critical care medicine. So, Dr. Shomudra Gupta, please come over the dais and invite our two players.
আমার 4 মিনিট আছে
এই দেখে না
আমার তো কথা বলতো দাদা
नहीं आवाज नहीं
আমার তো কথা বলতো 5 মিনিট
obese physicians who are sitting on the table and writing medications and are still remaining obese. And he's a surgeon who's working all day and looks much smarter. His BMI is maybe 22 and ours is about 28. So we are pro pharmacotherapy and still running obese, and he's running the show and a departmental head of bariatric surgery at his own clinic, which is in Short Street, na? Short Street and Bellevue Clinic. So Sarfaraj has been associated with me since my Bellevue days, and he has been a wonderful surgeon and a pure academician. His speech will enlighten us on the recent advances in bariatric surgery. I will request the House to give a vote of show of hands prior to this debate whether anyone is pro-bariatric surgery for management of diabesity, anyone pro-bariatric or pro-pharmacotherapy. So the House is probably not decided as yet, so we'll start the debate with Sarfaraz taking the show. We have a boxing round with Sarfaraz starting the boxing from the red corner, and we'll have Satyam from the blue corner, and I'll be the Narod of this session. I will try to play Narod, but both of them are so close to me, I won't be Narod. I will be enlightened by their gracious talks, and probably we'll have a show of hands at the end of the session so that pharmacotherapy wins or bariatric surgery wins. All over Sarfaraz.
Yeah, thank you very much. I was very impressed with Satyam coming and saying that, Dada, we are pitched as opponents. So I want to start with saying, Satyam, you have won the debate. There is no debate. So I bring greetings from my clinic. And the great debate is whether surgery at all is indicated or has a place in diabesity, or is it pharmacotherapy all the way. So my disclaimer is that I use a lot of anti-obesity medications, which includes the newer GLP-1 agonists, which means that I have a fair idea about both bariatric surgery and anti-obesity and anti-diabetes medications, whereas Satyam has knowledge only about the drugs. So I'm in a better position to talk about both of these things. Frankly, there is no debate. It's the way you put it. If you call it a debate, then it's a problem. But if you call it a discussion, then it's not a problem. Just like, let's eat, grandma. That's what you mean by it. But let's eat, grandma. So that means something else. So there's no opportunity. What it does is these kind of debates give us a chance to re-examine ourselves, our own practice. You might think that you're doing a great job with your patients, but perhaps you're wrong. I probably think that I'm doing a great job with my patient, but perhaps I'm wrong. So it's an opportunity to re-examine ourselves. By the end of this talk, I hope that I will be able to answer 4 questions for myself and for yourself. Where do we use bariatric and metabolic surgery? What is the efficacy of anti-obesity and anti-diabetic medications? What is the safety profile, and where can we use them? So let's start with the disease first. I think before we even start talking about diabesity, we first begin with the mother of the diseases, which is obesity. I'm sure when you all created this talk on diabesity, what you were talking about is a metabolic syndrome, and not essentially patients who are either only obese or only diabetic. It's like the entire metabolic syndrome. So let's start with the disease itself. So it's defined as BMI more than 30, but in Asians you can bring the BMI down because we are far more adipose. The latest definition is not obesity, it's called adiposity-based chronic disease, which basically means that this disease brings with it chronic diseases like hypertension, diabetes, chronic liver disease, infertility, arthritis, sleep apnea, and I can go on and on. This is not right. We believe that the obesity is caused by eating more and walking less or our activities less. This may be 50% of truth, half the truth, definitely not complete truth. This is the most accepted etiopathogenesis of obesity, which is the set point hypothesis, which basically means that it is our higher cortical function control which decides what is the body weight going to be, what is the body composition going to be. So I would like you to assume that your blinking of eyelids is 12 per minute. No matter how much you try, at your resting state it will be 12. Similarly, if your heart rate is 60, no matter how much hard you try, as soon as you sit down, your heart rate is going to be 60. You can probably change it a little bit over a few hours, but you can't change it for a long time. That's what homeostasis is all about. And body weight is no different. And that is why, no matter how much you try to change your body weight from 85 to 80 or whatever, the body knows the highest body weight is 85. It will always take you there. That's the set point hypothesis. What causes obesity? So, not just eating more and walking less, calorie excess, physical activity, but gut hormones, and which is where Satyam is going to be talking about. Hormonal imbalance, just the thyroids, the adrenals, the adipokines, they have a huge influence on our body weight as well as diabetes. Neural, the sympathetic, parasympathetic activity, that is one of the major controls of our weight, body weight. Gut microbes, we might not like to believe, but can you imagine just having the right kind of gut flora can influence your body weight? It's all proven. Chronic inflammation, if you have a body chronic inflammation, that sets your body weight. What kind of food do you eat? What kind of inflammation you have in your body? Psychobehavioral problems. So what kind of disorders you have? Do you have a binge eating disorder? All that is going to influence. And I have mentioned one thing at the last. And what's that? Genes. Okay, these are not the pants that we wear, the genes. And the genes control almost everything. Would you believe it? The latest update on genes was on influence on obesity. It influences how much you eat, how much you absorb your food, how much you store your food, and even your behavior. Half of the eating disorders like bulimia, anorexia, they are all genetic in nature. So isn't that surprising? And why am I saying all this? This is not even pertinent to the debate here. The reason is, why I'm saying all this is because unless we know what disease we're talking about, we do not know what modality of treatment to give to these patients. We must agree at this moment that the cause of obesity is polygenic, is multifactorial, and it's complex to understand. It's just not one thing. It's just not the gut hormones. It's just not the GLP-1. The treatment has to be individualized. It cannot be as simple as a second line. It has to be. You have to understand where the problem is and then rectify. So the management is plenty, but I will first speak from a surgical perspective. What have we been able to do for patients with obesity and diabetes and metabolic syndrome in a larger perspective? This is my first slide as an argument. Bariatric surgery doesn't work by one function. When I showed you the causes of obesity as accepted by the experts across the globe, this is what is accepted by the experts across the globe. Bariatric surgery works by calorie restriction, malabsorption, alteration of gut hormones, adipokine regulation, neural regulation, regulating the sympathetic parasympathetic activity, creating hypermetabolic state, changing the gut flora, and reducing chronic inflammation. And all that resets the hypothalamus. The set point is reset. I can just walk out of this door right now with this slide and let you all think whether you would like to consider bariatric surgery for patients with severe obesity. Is there any other management which can give you such a far-reaching effect? What kind of molecule do we have in the market? Now, this is the latest belief of experts. Bariatric surgery, when you talk about obesity, is polygenic. Can we change genes? No. Can we switch them off? Yes. If we run daily, we can switch off some genes. If we eat fruits and vegetables more, we can modify our genes. Switching on and off is the epigenetic phenomenon. And that's what we have in control. And that's what bariatric surgery is now considered as. These so many things that it touches and addresses is a mega epigenetic phenomenon. And that's why it works. This is our own paper, 9,617 patients from 20 centers and follow for 5 years, first author. And I can see that the mean BMI is 43 and it goes to 32 at 5 years. That's the mean BMI. So it's working for 5 years for most patients. Look at the Taiwan series, 15 years, still going down, still working for most patients. This kind of dramatic weight loss cannot be seen in any other therapy. So it has to be a surgical therapy which can give a dramatic weight loss of 30%. And I would go on to say that when you deal with severe obesity, with or without diabetes and other metabolic syndrome, this is not one of the solutions. This is perhaps the only solution now that we have. If the patient wants a solution, that's the only solution you have for severe obesity if you want to produce a dramatic weight loss. I don't want to bore you with the data. All of you know this data. The Swedish obese subjects data, what did it show? 2,000 controls, 2,000 patients who underwent bariatric surgery, followed up for 10 to 20 years. And they found that the death rate was lower in those who underwent surgery. The incidence of diabetes in those who underwent surgery was lower. The incidence of heart attacks in those patients who underwent surgery was lower. What more can we offer as a physician or a surgeon? If you look at the STAMPEDE trial, look at what bariatric surgery can give you when it comes to diabetes resolution. Not diabetes control, diabetes resolution. 5% with medical therapy. This is surgery plus medical therapy, and this is medical therapy alone. So I am putting in a caveat there. In patients with BMI 27 to 40, and still you see 30% versus 5%. If this was BMI more than 40, this figure would be like 50% versus 0%. What about satisfaction with surgery? Despite the fact that these come from excellent countries with good data set, most people are satisfied with the surgery, right? 3/4. The quality of life is improved. Of course, you would like to know what is the adverse outcome. This is the latest. Mortality is 0.04 to 0.3%. Serious complications about 1 to 4%. So yes, there is a downside. After all, the surgery that you're offering. What about the incidence of AMI and CVA? 0.14%. So yes, there is a downside. If you're going to give the surgery, there's going to be a mortality and morbidity associated with it. But what about the long term? People talk about weight regain, 5 to 25%. If you've done a diversionary procedure, 5%. If you've done only a restrictive procedure, 25%. This is about long-term data. And nutritional deficiencies, yes, iron and calcium deficiencies are seen in about 10% of your patients. So People talk about costs of the surgery. Yes, it costs about 3 to 5 lakhs of rupees in Calcutta. But is it cost effective? Well, compare it with the pharmacotherapy. Every month you calculate the cost. It's going to be realized in 1.5 years. So data on bariatric surgery, weight loss 30%, mortality benefit, yes. Decreased heart attacks, yes. Diabetes resolution, yes. NASH effect, yes. Infertility effect, yes. Quality of life improved, yes. Now I will touch upon what Satyam will have to speak on, and I think he's going to do a fantastic job. Weight loss is in this paper which I collected from PharmEasy. All these molecules, they give you 5 to 20% total weight loss. And this 20% comes from the drug which has not been launched, the tirzepatide. So this is still not seen. Most of them give about 5 to 12% of weight loss. So 100 kilo person can become 88 kilos, 150 maybe about 130 kilos, but that's what we are offering from these molecules which are there in the market. Now, I understand now that why the physicians are, and all of us are excited, is because of these GLP-1 agonists and GIP agonists. Like liraglutide, semaglutide, and tirzepatide, these molecules are showing promising results. And I'm also very excited. It's fantastic to have more molecules on the horizon. It helps us, it helps the patient, it helps you. So, I am not surprised as a bariatric surgeon that physicians have actually now saying and agreeing that GLP-1 agonists are working. Because that is one of the way why bariatric surgery works so well. So, if you are giving, let's say, 1 dose of GLP, the bariatric surgery is giving 200x of that same dose for a long period of time. Okay? That's what we've been doing. So I'm not surprised, and it's good that we are on the same page now. We are agreeing that it works. Now, data on obesity, anti-obesity medications, which comes from this large review, the most updated review, tells us something very, very important. I showed you the slide on bariatric. I'm showing you the slide on anti-diabetic and obesity medications. Weight loss, 5 to 20%. Mortality benefit, query, no data. Decreases heart attacks, only tirzepatide and the semaglutide showed some benefit dubiously, very small cohort. Diabetes resolution, no. Control, yes. On fibrosis, on liver, no data. Infertility, no data. Quality of life, no data. So we are talking about things which are nebulous, which are evolving. We still do not have data. We have bariatric surgery data for 30 years. But the anti-obesity medication, not so much. And if you look at the adverse effects, the label itself tells you don't prescribe it in patients with thyroid cancer or somebody who's got a history, or it can cause, and pancreatitis is a problem, gastroparesis is a problem, big problem in fact, biliary disease is a problem, bowel obstruction rarely, GI intolerance very frequently. So I've used these drugs, so I know that this do happen, the GI intolerance does happen, and lots of patients will discontinue. What I am worried about is that we are looking at a product which is a $2 billion market already, and it's going to be $3 billion. And I'm always worried whenever there's a lot of money involved, because there's a lot of negative track record of all the older medications. We had lorcaserin, which was withdrawn in 2021. I always fail to understand why they come in the market in the first place, if it is so bad. So many of these older products had problems with depression, suicides, as you all know, and cardiovascular related. The other problems which I would like Satyam to actually address is, I realize that you have to give them lifelong, so it's a recurrent expenditure, it's accruing expenditure. It's expensive, it's not cheap. It's like a lot of money every month, not many people can afford. 90% of my patients experience side effects, and it's ratified by literature, published literature. And drug discontinuation with liraglutide is 12%. Lastly, variable response. Not everybody responds the same. Some people respond with 2, 5, 3 kilos. Some people respond 6, 7. Some nothing at all. What's happening here? Long-term data absolutely lacking. So one slide, and that's my debate. That's my argument. This is your difference in the weight loss. Diabetes remission, no, yes. Mortality benefit, no, yes. Cardiovascular benefit, no, yes. NASH, no, yes. And if you ask me where do I see indications for these anti-obesity and anti-obesity medications, I see them in mild to moderate obesity with diabetes in rich patients. In really rich patients, and I can offer them, definitely. I like it. Number two, I use it just prior to bariatric surgery. Somebody's come with 180 kilos, and I want the liver to shrink. I will give them anti-obesity medications for about a month or two to get the liver down, a little weight loss down, get the diabetes more controlled, have less wound infections. And finally, after bariatric surgery, let's say 5, 10 years down the line, I see weight regain, or I see that some of my patients are not responding so well. I would have wanted more weight loss. I don't mind using anti-obesity medications in this cohort. So that's my indication. It's not endorsed by literature. I'm just saying that. And frankly, this is not a debate at all. We are increasingly realizing that all diseases are multifactorial, almost all, and therefore the treatment has to be multidisciplinary. It's not about Satyam not referring me bariatric patients or I not referring Satyam patients for medication. I think it's just a game where all these factors are involved, and all of us will have to get together to give some sort of a tailored algorithm for patients. So there's no fight. It's just a good discussion.
Thought of
Thank you,
giving a
Satyam.
rebuttal session to them, but probably they are rebutting themselves now. So I have stopped having the rebuttal session now. So only Shottam will come and then we'll wind up the session. Because
Satyam, all yours.
So we are on the Gaza Strip with the Israelis being now bombarded by the Hamas. May I request Shottam to come here and enlighten us on the anti-obesity pharmacotherapy, diabetes management by pharmacotherapy.
Well, good afternoon, everybody. After Dada's lecture, I am literally confused. Where do I stand now? Whether I should use things at all. Okay, so... এই তো আমি তো জিতবো তখন এরা ঘুম থেকে উঠবে আমি জিতবো হারবো পর কথা তোমরা ঘুম থেকে ওঠো ভাই আমার স্লাইডগুলো দাও আমার স্লাইড কালকেই দেওয়া হয়ে গেছিল না না কোথায় স্লাইড স্লাইড নেই এখানে কোথায় স্লাইড বুঝতে পারছি না ব্যাপারটা না সরফরাজদা যখন তোমার সিনিয়র ছিল তখন আমি ক্লাস 3-তে পড়তাম এটা নিয়ে কোনো প্রশ্ন উঠবে না তাই কই স্লাইড কোথায় এখানে নেই আমার কাছে পেন ড্রাইভে না মোবাইল আছে আমি তো কালকেই রাতে পাঠিয়ে দিয়েছি না ল্যাপটপ নেই আমি তো মেলে পাঠিয়ে দিয়েছি
So, in the meantime, when Shottam prepares his slide, our understanding of bariatric surgery and the management dates back to our understanding of the gastric bypass surgeries. So, I would like to request Sarfaraz to also enlighten us regarding the various bariatric surgeries to perform, apart from the the Roux-en-Y, which is the gold standard. We are having mini gastric bypass as well as mini gastric. So please enlighten us on this topic about 2 or 3 minutes after the session is over.
হয়ে গেছে
Shottam.
Surgeons and the pharmacotherapists.
Good afternoon, everyone. Basically, at the outset, I am a bit confused, but I would like to share my discussion in the form of a story which started way back in the year 2017. And here, a patient travels for relief, and you will understand she is a 33 years old diabetic hypertensive with a huge body weight, BMI of 42, has number of complaints with an HbA1c quite high, and also the blood pressure is high in spite of multiple anti-diabetic and antihypertensive medications. And we understand, as Dada told, that this patient should be a candidate for bariatric surgery. Dada showed us many data, but here when I see many more data as far as 2019 was concerned, this was the problem. There was still, even after 30 years down the lane, there was still low quality of evidence, and there was a critical need for high level of evidence. And it was at this time the GLP-1 analogs came into the market. And if you see the 12 RCTs where bariatric surgery was compared versus medical and lifestyle treatment, we find that the number of patients, the low power, there were very less number of patients. They were either not followed up for long, but yes, there are studies now where patients are followed up for long. I will show them also. Now it was at that time the GLP-1 analogs came, and the first idea whether it is time to replace bariatric surgery with GLP-1, and this was a beautiful article, and let's see what they say. Yes, as Dada said, total body weight loss of about 30% was obtained, no doubt, and it was shown that this was markedly because of an elevated GLP-1 response after RYGP. I don't know what is RYGP, as Dada told, I know only medications. Now, at that point, what was the GLP-1 analog available? It was liraglutide. And how much weight reduction did it exhibit? Around 10%. So, the cardinal question of this review as to whether GLP-1 therapy can replace bariatric surgery was based on the current published knowledge for now is known. Bariatric surgery cannot replace, but perhaps someday, and it continues in this area, future combination therapy of optimized peptide analogs may provide more pronounced weight loss, at which point they may supplement, complete, or possibly even replace surgery. Now at least the liraglutide has given me the same podium to run behind that. Maybe I cannot compete with that, but I am at least on the same podium. Welcome 2021. Here comes semaglutide, painless once weekly injection, and in the step 4 trial, what did it show? 18.5% approximate body weight reduction. And if you see the data of the percentage of patients who lost more than 15%, I will try to help you with why 15% is important. It was wide and large. Around 50-60% patients lost more than 15% of their body weight. And how did this lose? This is what we want basically. There is a total fat mass loss and there is an increase in lean body mass. Now 2021 I am again running, but I am an inch closer to that. Come 2022, tirzepatide was launched, we delivered 22.5% of body weight loss. And now Dada can hear my footsteps behind. And welcome 2023. The triple drug was launched and it showed 24% body weight reduction, and patients receiving also found that there was a good number of patients who lost 30% of body weight. Now, forget all these dual agonists, forget all these triple agonists. This is a 2023 paper which showed only on the agents which are widely available how much weight reduction was there. And the article showed with a combination of AOMs, a GLP-1 receptor agonist was 32.5%, mirroring average weight loss experienced following metabolic and bariatric surgery. Now I am on Dada's laps. And Dada will be very happy with that. I know that. Now, why was this 15%? The reason being, once you have a 15% weight loss, this is the data which shows. Sujay sir also showed this data today in the afternoon. Type 2 diabetes remission. There is CV mortality reduction. There is decrease in heart failure events. And along with that, you get an advantage of all the events. So that's why it's important. So when bariatric surgery is compared versus medical, on a long-term basis, as far as microvascular endpoints are concerned, post-bariatric surgery, there was no improvement. But again, when the macrovascular endpoints were concerned, I know there was limitation to the study because of data again. Let me show you the CVOT results meta-analysis with the pharmacotherapy. And yes, we all know how the robust were the CVOT's data and how much the numbers say for themselves, how much reduction is there. Again, forget weight loss. GLP-1, SGLT to reduce cardiorenal risk independent of this. Pioglitazone reduces ASCVD in spite of causing weight gain. Now again, we need to say this untold story or keeping this in the back. Still, out of every 1,000 patients undergoing bariatric surgery, the recent data says 2 might die, and around 10 will have 30 days serious complications. And this may be underreported because there is problem with reporting. Coming to the continued problems, but depression, new opioid onset use, and most important, revision surgery. One surgery followed by another surgery. Right now in US, revision surgery is the third most common surgery occurring. So these are all the complications. Now this is the Nature 2023 data of day 30, and just see the percentage of complications at day 30. You will realize that at what cost? Only for reducing 25.9% body weight, approximately. So that's not taken. we don't talk about this. This is a very rare complication, bypass only. The problem is with this is, after 10 years, 12 years of a MMY, suddenly a patient comes to you with a blood glucose level of 47 and which is diazoxide resistant. And for all of us clinicians, when such a patient post-bariatric surgery comes, at least I will think that this is dumping syndrome. Give the patient some dietary advice and let the patient go, only for a catastrophe. Because this bypass nesidioblastosis is very challenging to diagnose. For example, when you have diagnosed it, you are a team physician, you are with a bariatric team, which I am quite unsure how many bariatric teams have expert physicians and endocrinologists within in India. But if you have diagnosed, what is the management? Second surgery. Remove the pancreas, half, full, or even the spleen along with it. And then you think your patient will get respite. If you think so, the authors have something different story to tell. They found a significant rate of recurrent symptoms post-operation of nesidioblastosis. Only half of the patients were classified as highly or moderately surgically successful, and 25% had no benefit. So for a hypoglycemia, you have no benefit. Now for conclusions, with the increased rate of weight loss surgery, hypoglycemic nesidioblastosis will increase in prevalence. So a rare complication, you are now converting into a common complication. So you have to have your beds attached now. And what you find, even after years of surgery, suddenly patient lose consciousness because of hypoglycemia. Now standing on 2023, I am a confused human being. I am a confused physician. The reason being, till date, I thought the treatment of hypoglycemia was 15 grams of glucose. Now I need my surgical colleague to treat hypoglycemia only because I referred the patient for treating hyperglycemia a few days back, few years back. This is confusing, and standing on 2023, I have why when I speak about bariatric surgery. Obesity lies in the brain as just another tumor. It is basically the hedonic cure. Neither bariatric surgery nor the medications is going to help if we cannot modulate the lifestyle of the patient. And I agree to the Dada on this point. And we have to understand it is only the interplay of the lateral hypothalamus and the ventromedial hypothalamus, and they are mediated by the gut-derived hormones. So you need hormones, you need adequate levels of hormones in the blood. So you can always have exciting tomorrow for anti-obesity pharmacotherapy, starting from the gut microbiome, starting from the gut-derived hormones, everything. We are there. Finally, Indian Railways has achieved 100% electrification. Now, if you are still adamant on going to produce your own gut hormones by yourself and generate power and move, then you have to be rest assured of the adverse effects. Please stop. I have easier way to give you gut hormones. I will give as much as you like in a much safer, easier, convenient means by a weekly injection, and you will get all the results which I have shown. Did we forget of our patient? The huge patient? Today, she is a lovely lady, a 65 kilos body weight, HbA1c 5.6, only on metformin 500 after dinner, no antihypertensive, and take it from me, I did not use even GLP-1 and all for this patient. So, only by medical nutrition therapy, more or less lifestyle, we can yet come to terms. So this was well foreseen in 2008. The hope for diabetes lies in the dissection of metabolic pathways uncovered by bariatric surgery and applying the findings to the development of effective medical therapy. We can't operate on 24 million Americans. So what I presume is the bariatric surgeon, Dada, will remain ever as our academic guru for all we practicing physicians, and Dada will always refer patients to us. On that note, I rest my case.
expected. I knew that Satyam will win the debate, and I'm so happy for it. So I have always believed that if a lesser strategy can work for any disease, it should be accepted. Even if that means that I should go out of job. So definitely there is no doubt about it in my mind that if the vagotomy is inferior and the PPI can work, the PPI should stay. Omeprazole should stay and vagotomy should be out, which is correct. In regards to obesity, I think Satyam, we are as a whole, the entire house, I'm not addressing you alone. I think when we talk about obesity, we forget this chronic disease like diabetes. And when you say weight gain is a complication of bariatric surgery, I think you misunderstand the game. You will get weight gain even with your drugs. You will get inadequate weight loss with your drugs. You will get variable response with your drugs. And the reason is because obesity is a chronic disease, it is not going to be harnessed as well as you think. Number two, there is still time where long-term data of the AON has to come. It's been there for what, 3 years, 4 years? And we try to compare ourselves with something which has been there for 30 years. I am not saying it's not good, I am saying it's too early to say. How soon did we introduce Lorca-7 and how soon did we take it out of the market? There are n numbers of reasons why this happens. Much of this is to do with the kind of trade that we are in. I think we will need to wait till we stamp our feet on the ground and say, you know what, this is better than surgery. We need to wait. Number three, you spent 5 minutes on residuoblastosis. I mean, that's a complication just seen in 100,000 bariatric surgery patient. But you spent 5 hours or 15 minutes on that. And I was surprised because, you know, in my 17 years of practice, I have never seen an residuoblastosis, despite the fact that I've done more than 1,000 bariatric surgery. So I think that's a very, very rare complication to talk about. Just like you wouldn't like to talk about a medullary thyroid cancer after an AOM. I mean, how frequently is that? It's pretty rare, isn't it? Nobody wants to talk about it. It's just there, you need to know about it. So that's another thing which I thought that it's not fair to talk about one complication which is seen in 1 in 100,000 and spend 30% of your talking time on it. And this is just a way of understanding that our surgery increases GLP in some patients in such a manner that it can be too much. So it's good, it's a science that it's offering us. The problem is offering us something to think about. Finally, I think if the anti-obesity medications give the same efficacy and less side effects, it should definitely be replaced with bariatric surgery. I please do. But I don't think we are there at all yet. I showed you hard evidence. These are evidence by the updated review comparing head-to-head the surgery versus medical therapy. We're right. It's probably someday we will reach there. But that day is not 2020. It's not happening yet. There's no long-term data to say anything that you said in those 10 minutes out of your 15 minutes, which was not necessary with us. The past record of anti-obesity medications has been over-promising, under-delivering, bad side effects, retraction from the market. All I can say is, if you win, I will win.
Dada rightly pointed out why you guys see residuoblastosis, such a rare, but it is one of the rarest of that which can cause mortality. And maybe I thought that was the reason why I talked about residuoblastosis, and with increasing number of surgeries I already mentioned, the rare one will no longer remain a rare. Now as far as the evidences are concerned, for all the pharmacotherapies which are recently recommended, all pass through very stringent CVOT. The medications which Dada was mentioning, the Lorca-7, the previous drugs which went out of the market, they did not pass through the CVOT trials. That's why there is good chance that none of are going to go out of the market and they will have their response. Okay. Now the other thing is that, as again I told, I reiterate is that diesel engines will remain in the Indian railways. It will not go. Okay. There will be loco failure. There will always be accidents, which are very rare accidents with increasing safety, and there we will need diesel engines to clear the damage. Okay, so I am always on the same flag as Dada was saying, that yes, we will require diesel engines. Okay, but the call of the day for the future will be the electric locos. Okay, and there will be diesel engines, they will help us, and at times we will find that we both will work together. As we have already seen, that in most of the cases, when bariatric surgery, post-bariatric surgery failures are there, it is the GLP-1 analogs which are being prescribed. So, at the end of the day, you are again coming to medications when your surgery fails. So, why not from the front? Why not from the start? We can always get, Dada has said, yes, it is not coming in. Okay, it is not coming in 2023. I am not saying that it will come in 2023. But 5 years, 6 years down the line, I am always there with Dada. No doubt about that. Thank you so much.
May I request both speakers and request 2 minutes from Sarfraz to explain the various types of bariatric surgery which are performed. Okay.
Yeah, so basically bariatric surgery is a laparoscopic surgery. So typically patients come day before, get operated the next morning, and either 24 to 48 hours they go home. What are the kinds of procedures? I think for all of us, simply put, in first one, which is the sleeve gastrectomy, the commonest one, 80% of the stomach to the left is taken out, and the banana kind of a stomach is left behind. Very simple procedure, not difficult to understand, doesn't alter the GI continuity, and gives excellent result. In some of the recent trials that showed it is giving almost an equivalent result for diabetes also, which is a little strange. The gastric bypass, we want to divert the duodenum. Based on literature, published literature that you all know, that when you bypass the duodenum, the GLP agonism occurs, and therefore any of these gastric bypasses, what they do is, they will break the stomach into 2 parts and not allow food to go into the duodenum, and that proximal part of the stomach is attached to the intestine. So that's a gastric bypass. So gastric bypass, sleep. Don't go into any more of these intricate details. They are unimportant. They are like hair-splitting details. What is important is endoscopically. Also, there was a balloon. There is still balloons around. They have intolerance, crampings and vomitings, not very popular. But what is getting a little popular is endoscopically allowing to stitch the stomach from inside. So I can create a smaller reservoir in people so that they eat less than they used to. It gives about 15 to 20% of total weight loss. So that is another area which is there, and these are all available in our city itself. So these are 4 things that you should know. The rest of it is not.
May I call Shottam to the class, please? So, show of hands to pharmacotherapy. Show of hands for pharmacotherapy. So, already declared himself lost. So, please. Actually, it's a collaborative effort, and I would request the organizers to have a gastroenterologist, invasive gastroenterologist into the discussion next time. Because they are into interventional gastroenterology in weight loss surgeries, they are also collaborating with them. So I would request them to have a session with them also in the next lecture meeting. So may I end the session with Sanjayra.
Thank you, sir. Thank you so much. I think we have enjoyed
So
the
I think there is no show of hands. It's a pharmacotherapy one, when it's all 5 nil.
What is the cost of anti-diabetic medication?
Now, sir, right now what is happening is, because of the company initiative, even with 6,000 per month we can get it.
Okay.
Now Now it's time to felicitate Dr. May. I would like to request Dr. Samudra Gupta, sir, to please felicitate him. And now I would like to request Dr. Shah to please felicitate the moderator. The felicitation already done in the hall B. Thank you, sir.